Chronic lymphocytic leukemia is the most common leukemia in the United States. It's an indolent disease with a slight male predominance and an average age of diagnosis in the early 70s. It's a disease where a third of patients are observed indefinitely, a third are treated sometime in the future, and a third are treated immediately. So it's a heterogeneous patient population. And oftentimes, what helps us to decide on which therapy is important for patients are the molecular and genetic prognostic testing that we perform. And so go back a couple of years, let's say before 2014, all patients were treated with chemoimmunotherapy, but the genetic testing were able to identify patients who didn't do so well, who had poor outcomes, shorter survival, shorter remissions. Fast forward to the present time, we're able to identify patients who are likely to not do well with chemotherapy and provide targeted agents like ibrutinib or venetoclax or acalabrutinib, and those patients largely overcome the poor risk features of their disease and can do well. And in fact, there have been many trials comparing modern therapies, targeted therapies to chemoimmunotherapy combinations, demonstrating a survival benefit. Well, that's great, but the most important thing is whether or not patients are having this test performed. And so the informCLL registry is a prospective registry, US-based, approximately 1,500 patients who participated, all of whom were followed for a period of approximately 5 years during a time period where all had access to agents like ibrutinib in the US. The drug was approved in 2014. And so the data that I'm presenting at the ASH meeting are allowing us to look at these patients to identify which patients had appropriate prognostic testing performed prior to therapy in the frontline setting or in the relapse refractory setting, and then to take it one step further and say, well, if they've had testing, were the results interpreted appropriately to guide clinical decision-making? And the take-home findings from this presentation was that only a minority of patients had the testing that experts would recommend. About a third had FISH testing. About 10 to 12% of patients had next-gen sequencing for TP53 mutation or IGHV mutational testing. Even more surprising from the data set was that even when they had the test and they had the poor risk feature, in 20 to 30% of the time, they're still having what we would consider not the standard of care, chemoimmunotherapy. So this type of study is important for many reasons. First and foremost, it's proof of concept for why a registry is important. Secondly, it helps to guide the community in terms of where efforts need to be made for education for both patients and providers. It's important to perform appropriate prognostic testing. It's also important to interpret it in a way that guides to the best treatment decision for patients. And so really a pleasure to present these data because it does provide an area where there's need for further education for both patients and providers, and again, supports the role for a registry and how that adds to the body of literature for patients with CLL.